Sup, guys? Welcome to the PT Good podcast, where we talk all things ortho, from physical therapy to training. My name's Kane.
And my name's Mark.
So, Mark, what is on the agenda for today?
Kane. All right, man. Headaches. So we want to talk about this. We want to talk about headaches in the context of sort of continuing the previous episodes we had, which were cervical radiculopathy. We feel headaches can be assessed very similar to radiculopathies. We feel like they can have a mechanical component, and we wanted to talk about how we assess them, interventions we provide, and just what the management of headaches looks like. So, Kane, why don't you start us off? Where do you see any kind of overlap between like headaches and radiculopathy, how they respond mechanically? And let's start there.
So I guess the biggest thing for headaches is trying to figure out whether or not it is mechanical, right? If it is non-mechanical, we're probably not treating those.
And
you
by
have
mechanical,
to identify it.
You mean what?
Like it responds to some sort of intervention that you're doing. Yeah. It's the same way with anything else that you're treating, like low back pain. It's either mechanical and responsive, or it is non-responsive or mechanically inconclusive, and you have to either do something else or you need to refer them out because that is just not within our, I don't want to say scope of practice, but we can't treat those, right? If it's not going to respond to our interventions, it's just not something that we can treat. And it may be something that we can point our patients in the right direction, at least. But for the most part, I think that the identification of whether or not it is a cervicogenic headache is super, super important, because if it does not respond, okay, we just talked about this. You're probably going to refer, especially if it sounds a little suspicious, a little red flaggy. We'll talk about those in just a second. But if it is mechanical, if it is a true cervicogenic headache, I think that the easiest way to think about these, I'd say like 95% of these that I see, I would classify them as a radic or as a derangement, if you want to use the MDT term. But for the most part, these guys are going to respond with a directional preference. They're going to respond rather quickly as well, too, or at least they certainly can. So I think that that's probably the biggest thing, is figuring out whether or not it's something that you can treat. That is like step one. That goes for like any other impairment too. But I think for headaches, it's definitely up there, just because you want to make sure that, hey, if it's a true cervicogenic headache, I can treat this. If it's a true migraine, probably can't treat this. But sometimes just because they say that they were diagnosed with the migraine does not always mean that it is truly a migraine. So,
some of the symptoms you see associated with a migraine, such as maybe some like slight visual changes, or the nausea, or the sensitivity to light, things like that. Like, certainly there are cases where it could be a red flag, but sometimes it's due to a mechanical issue. You can almost use those symptomatic response and the sensitivity as a baseline, like you talked about addressing it as a derangement, right? Or looking to see if they have directional preference in regard to the headache symptoms. You can use all those subjective complaints as baselines for your mechanical assessment. I think like you were saying, it's sometimes you got to make sure the patient's being screened, right? So I think sometimes people get a little hesitant when it comes to headaches. It's like, you're dealing with the person's head, it's their brain, they got these funky symptoms. But when, we've talked about this a lot in basically every episode. When you have this consistent mechanical framework, this assessment you can use, it's as long as you rule out all the bad stuff, you're just applying this standardized assessment to the patient, gauging symptomatic response, watching them move, and then seeing if it's something that we're able to help them with.
And I think that getting the relevant details from their history is, once again, pretty important here. It's the same thing that we talked about in previous episodes, right? Where some of their symptoms may not be making too much sense, or maybe there's like variability. But for headaches, what I'm trying to look for here is maybe there's a trend, right? Maybe they're able to identify some sort of pattern, some sort of habit that they're doing that is contributing to these headaches or the intensity of them, and then seeing if, once again, there's some variability there that I am just like, hey, this sounds a little off. Like maybe they're super stressed at work and they are on the computer and they have symptoms then, but when they're at home, they don't have those symptoms, right? So maybe something else is going on that could be triggering that. And it's not necessarily like just looking at a computer screen per se. Maybe there are other factors that could be contributing to it as well.
Yeah, I mean, just building off that, like I can think of a single patient where similar kind of thing. It bothers me sitting, but it really only bothers me sitting when I'm in class in college. But if I sit at home and I'm on the computer, it doesn't bother me, right? So maybe there's some kind of environmental, some kind of different factor that's not mechanical that we're looking at there.
Yeah, and I think that kind of understanding how stress can help to contribute to some of these issues is definitely something that I feel like kind of gets overlooked as well too. Yeah. Is there anything else that you typically look for in the history portion where you're like, this is kind of pointing me in the direction of it being a cervicogenic headache?
So certainly these can be constant or intermittent, but I think if they're intermittent, and if the question I always ask when it comes to establishing if it's something mechanical, hey, do you have good days or bad days, right? That would tell me that the symptoms can change depending on something the patient's doing, right? Even if symptoms are constant, if they're changing, increase at certain times, decrease at certain times, that leads me to think, okay, there's some kind of pattern or something happening here, and then it's my job to see if it's related to movement, right? So the pattern of the symptoms is one thing. Another thing I look at is just if it's something they're able to change on their own. If they notice, and this goes into the pattern thing, hey, like if I sleep on my back and I have 0 pillows or 1 pillow, then, I wake up and my head's really bothering me. But if I'm kind of, have 2 or 3, if I'm stacked up, or if I fall asleep on the couch a certain way and I get up, it's really not too bad, right? So the person being able to demonstrate some kind of link in response to movement or positions, and then the variability of symptoms are certain things I look at in subjective. Anything else you look for?
I think this isn't something that's always there, but I think asking if they have a history of neck pain or stiffness, anything like that. I think that a lot of times with headaches, you don't always get that response. Like they may or may not have limitations there or a history of neck pain. I've had plenty of patients that are just like, nope, I never had anything like that. I never once thought about my neck. Sure. I just know that my head hurts.
It's my head.
And so you get them to move, and then all of a sudden it's gone still. And then others where they're like, no, my neck definitely hurts. And then when my neck hurts, my head hurts more. And so when they give you that, that is a T-ball.
Man, I don't want to get ahead of myself, but that sounds like peripheralization.
It is, and that is pretty much why I think that Mark and I consider it to be a radic, is because your symptoms are manifesting themselves peripherally away from the spine, right? And so I think that that's where considering if they have that prior history, that is important. But I do think that tracing some of their symptoms can be helpful, like the pattern of their headache, right?
Sure.
I'm finding for the most part that for cervicogenic headaches, they are usually going to run anywhere up the spine. They may or may not have that neck pain, but they're usually going to complain of pain that goes into the temporal and to the frontal aspects of their head.
Sure.
It's usually like diffuse from what I've seen. It is not usually like a cluster headache, or it's not necessarily like a migraine per se, you may still get some of those like nausea or dizziness,
Right.
or maybe even some like ear like symptoms as well too, like ear fullness or ringing. Those are definitely symptoms that can come on with cervicogenic headaches as well too. But I think that those are definitely something to consider to help you tease out whether or not it's a condition that you can actually treat, or if it's something that you're like, oh, this is sounding more and more like something that's out of my wheelhouse, and maybe it's time to refer them back to their PCP or to a neurologist, whoever they need to see, to get their symptoms in check. Are you seeing a similar trend?
Yeah, in terms of like the pattern of pain, certainly. Like I mean, it's almost, there can be some overlap, but it's certainly like presentation wise. Like I see people where it's like base of skull and then just up like occipital lobe, temporal, frontal, just that kind of wrap type thing. Sometimes it's unilateral, sometimes it's bilateral, and then I see the people where it's, I have a headache, but I also have neck pain, and then maybe they also have arm pain with it too. But they have the neck pain's a component, right? Is it their primary complaint? Is it their secondary, tertiary complaint? It depends on the individual, right? So I see it both ways, where it's like, no, it's a headache, my neck, it's tight or something, but it doesn't hurt. And then you have the people who have the associated neck pain and perhaps even upper extremity symptoms in addition to a headache. So do you how about presentation wise, like, is there anything else you see in terms of variability? I mean, I know like just like for me, like I said, and like how you hinted at the beginning, if it's a mechanical headache, I mean, we're addressing it mechanically, right? We're looking for directional we're addressing it like it's almost like any other thing, anyone else with pain. We're looking for directional preference. We're looking to see, like, is this a derangement? Is it going to respond mechanically? So sometimes I see the people where it's like, I have neck pain, I also have arm pain, maybe I have numbness and tingling, I also have a headache, right? We need to begin by addressing them all together and monitoring each individual symptom in response to movement. Maybe the headache's going to respond differently to the arm or neck pain, right? In terms of they could be all together, they could all simultaneously respond to the same movement. Maybe it's something that has to be, each symptom has to be taken individually, right? You need to combine different movements or use different movements for each individual symptom. But yeah, what about like presentation wise? You hinted at it a bit. Do you see anything more than the people who, just have the headache? Do you see associated symptoms, like other things related to the cervical spine?
It definitely can happen. I don't usually see, or at least I haven't seen, people with like traditional radicular symptoms as well as a concurrent headache. And the point that Mark brought up is actually, I think, a very, very important thing. Is if you are treating a headache, especially with repeated motions, it could potentially be one movement that gets rid of everything, or you might have to continue to explore a little bit more. And that's where playing with some of your force progressions and some of your segmental mobility stuff is going to be really, really important in teasing that out and kind of figuring out what thing or deficit you want to tackle on first. But I think that is going to be a topic for later on in the episode when we discuss the treatment options.
I'm excited, man.
All right. So, Mark, we talked a little bit about these different types of presentations, the different headache types. I mean, there are clusters that help us figure out, like, if it's a migraine and what type of migraine, or if it is a cervicogenic headache, or anything along the lines of that. What is your experience with like classifying headaches? Do you put a lot of merit when it comes to figuring out like what type of presentation that they're having?
Like, now, are you talking about I don't know the name of the organization. I think there's like some kind of headache organization that's got like, 100 some different classifications. Are you talking about classifying in that regard or something different? Because if you're talking about, I mean, in that regard, it just kind of, I don't know if it needs to be broken down that much. I think, try and keep it simple, right? Is it going to respond mechanically? Is it not? And can we consistently have an improvement in symptoms that's long-lasting in response to movement? That's what I'm looking for, right? I mean, as long as we've cleared them, red flag-wise, nothing crazy is going on, there's no sinister pathology and needs immediate medical attention, I'm looking for the symptomatic response to movement. So in terms of classification, not really. You know what I mean? Like, is it tension? Is it migraine? You said, the cluster type ones are maybe, I don't know, less mechanically responsive, but regardless, I'm getting a history, I'm getting my symptomatic and mechanical baselines, and then I'm having the person move, right? So the classification to me comes more from a mechanical classification rather than the headache classification type thing. At least that's how I approach it. Now, I don't tend to. I'm a PT. I don't tend to treat I don't treat headaches differently than only mechanically, right? So I see the ones that respond mechanically, and that's how I treat them, and it seems to work. So I don't find that the really finite classification from the headache symptoms is something that aids me clinically.
Yeah, I would 100% agree. I think it's so funny because to me, like when we're talking about stuff like this, it's either it responds or it doesn't, right?
Yeah.
Like if it comes down to all the intricate different like classifications and trying to figure what exactly is going on here, it's going to be the same thing. You're going to hear this from me for almost every single body part. Does it matter? Yes or no? Yeah. I would more than likely and more than often say no, because it just isn't going to help you in your assessment, in your treatment, etc. You need to find out whether or not it's mechanically responsive first. That is the biggest thing. If it is mechanically responsive, then sure, you can go into whatever classification you want to go into to figure out what their biggest impairments are and how exactly you're going to treat it. Right. If you want to go into this as in like, oh, they are responding mechanically. Now we figure out, oh, okay, is it a cervicogenic headache where they respond to directional preference? Is it something that they need maybe some mobs or manuals to get some of their segments moving better? Or maybe it's a motor control issue that's contributing to it, right? These are all the different classifications that if you're going to go down that route, that's pretty much where I draw that line, where I'm like, okay, I probably wouldn't push too much further than that. Learn the basics of the different headaches and just go on from there. Like if the most important thing that I would probably say is figuring out what is a migraine and figuring out and understanding that migraines can have auras or that they don't necessarily have to have them as well too. But I think that that's really about as in-depth as you really need to go for someone who is just learning to treat headaches. I just don't find it to be super helpful, but I do find the next part to be very helpful, and that is figuring out whether or not something is red flaggy when it comes to headaches, right? So we talked about mechanical headaches. These things are things that are within our wheelhouse. Red flag headaches, those are not in our wheelhouse. Those people need to get out. So what are some of the things that you are usually looking for when you're like, oh, this is not it. Like I am not treating this.
So an easy one is, I think, headache related to trauma. I mean, yeah, you can. I mean, if we're thinking concussion, like sure, like can you have maybe? I mean, I've had this multiple times. Old concussion, and then they develop a derangement afterwards. But if it's like a trauma related thing, yeah, you may need, and they're coming to you, and you're the first line provider. Maybe some other, maybe some imaging, something like that needs to be done before you start to look at their neck. Another one. If they haven't ever had headaches before and all of a sudden they just have new, intense onset headaches without any known cause, it's throwing up some flags. easy thunderclap type headache, right? I mean, for concern for some kind of vascular type thing, right? That's something we're not going to handle. The other thing for me, and I think this is, we talked about the symptomatic presentation when it comes to like nausea and visual changes, and you said the ear fullness, and I'm going to say tinnitus or tinnitus.
Tinnitus.
Yeah, that's what I said. Tinnitus. If you have those kind of things, like I said, they can be symptomatic baselines. They're not automatically red flags. But if you have like those kind of symptoms, especially like the visual type changes, and it doesn't really change in response to movement, it's like a constant, always there type thing. I'm always nauseous. I always have this visual. I have double vision all the time. It's like, that's kind of strange, right? I don't know if that's, I said, a lot of flags going up there. Anything else you look for?
Whoa, Mark, did you say thunderclap headache or no? I think that is
I did.
Probably.
Wait, you messing with me?
I just wanted to make sure because
I did.
probably okay. That is. I've seen that one time and one time only. So I just wanted to make sure, but that was one of the weirdest evals that I've ever seen where they had quote unquote the worst headache of their life, a thunderclap headache. It was literally in their words. And then they came in, nothing changed. They had like severely uncontrolled high blood pressure. They had a lot of psychosocial issues going on, and the doc actually said that they were safe to be treated. And I was like, oh boy. Yeah, I definitely did not feel comfortable with that one. That was a tough one to get through. But I just wanted to make sure that was said, just because
it was said. All right.
That is like one of the top ones that I would say is, like Mark said, new onset of a headache that they didn't have headaches before, and then the worst headache of their life. Like that is telling me like, oh, something's going on. And obviously look at your other contextual factors, right? Like make sure, like, does it make sense? Are they really hungover? Like, is that the kind of headache that we're talking about? Or did they have like some motor vehicle accident, some sort of trauma, and now they have a potential concussion, right? That's another something that we have to consider. And it's not necessarily a red flag, but it's still something where we're like, okay, we got to keep it on our radar, you know?
For sure. Yeah.
All right.
Let's get to the good stuff.
Moving on, now we're getting on to our physical exam. What types of trends are you seeing here when you're going through like an examination of them? Like, are there any particular things that you tend to look at, or things that you kind of default to that's a standard for your eval?
Yeah, I mean, standard for my eval, let's just say my eval standardized, right? So I'm going through my subjective. I'm going through objective is consisting of my movement screen, a single cervical movement in each plane, gauging symptomatic response, and then, any kind of other relevant baselines. Are we doing MMT, reflexes, stuff like that? And then we're going into our repeated movements, right? So something to keep in mind with this population is sometimes, especially the ones where, like Kane was talking about, where it's like, it's head pain and it's their primary complaint is a headache and they don't really have secondary cervical pain or radicular type symptoms, they may not have movement loss. So we talked about the derangement presentation in regards to radiculopathies. Typically we see an obstruction of movement, right? This presentation may not have it. To me, I don't know, maybe it's just people have had recently. I find that they usually, maybe it's a 50-50 type shot, right? But the pure headache, like head pain, they may not have the movement loss. So something to keep in mind, just because they can retract fully or extend fully, stuff like that, and they don't have movement loss, they will still typically have a symptomatic response. So that's what you want to monitor. They, at least in this presentation, again, when I'm looking assessment-wise, we need to demonstrate a link between a certain movement and the symptomatic response. So we'll talk more about, treatment-wise, But instead, if we're looking for directional preference, if we're looking for that mechanical response, then we want to establish that link. So that's what I look for objectively. Like I said, the only thing that could be different in some cases is that you may not have the obstruction of movement, but you will still have a symptomatic response.
So even if you may have like trace movement loss where you can't detect it, maybe the patient can detect it, right?
Yeah.
Or maybe their neck just feels different when they're doing that motion. I think collecting that information is definitely helpful. But you may also just get the presentation where you just don't get that, you just don't get any other neck symptoms, right? And with that, you're essentially losing a part of your mechanical exam. So this is where you need to be very comfortable doing your repeated motions exam if this is the route that you're going to go down. Like, this is just how Mark and I treat. And it's just become so standard and staple for us that even if we're not seeing those range of motion restrictions, we're still able to test and retest and making sure that we're getting our comparables and seeing if we can change those with our repeated motions testing. That is the biggest thing. Is like, we always talk about symptom response, but in something like this, if you're trying to make sure if something's mechanical or not, well, you really got to make sure, like, hey, do we have something to compare it to? And then B, is our intervention effective or not? That is going to do a large chunk of your job in regards to ruling in or ruling out if it's something that you can actually treat. Now, the one thing that I did want to mention, and I don't know if this is something that that you may do or if you've noticed, but for headaches, if a patient doesn't have symptoms, it tends to be really hard to actually, to be confident in like what you're doing, what you're assessing and stuff like that. If you really think that it is truly cervicogenic still, for the most part, if I can't detect anything like that, if I can't find a comparable, I still send them home with what I think is going to most likely help them and see if there's a change in their frequency, their intensity, or in any of the patterns that they've noticed.
So
right?
You took the words out of my mouth. Like, at that point, they're monitoring frequency, which is another baseline we can gather subjectively. Hey, how often are you having these headaches? Because sometimes they can be episodic in that it's like every couple days I get it, something like that, right? So if we can start to develop that pattern, and it's something I track over time when people come in with their primary complaint is headaches. It's like, I usually get a headache 4 to 5 times a week, and then we check in, we've done a couple of visits. It's like a month later. Actually, the last week I've only had like 1 or 2 headaches, right? So especially if you're having if you're unlucky enough that where they're asymptomatic and you send them home with the movement you think is going to benefit them, and then you just track the frequency over time, right? Maybe they don't end up having a headache for, the couple follow-ups, and you can just assume, hey, we apply this intervention, the frequency of their headaches have been gone for 2 weeks when that hasn't happened in the last 2 years. Yeah, clearly there's some kind of response there.
Now, the one thing that I do want to add on top of something like this is where if you can't find a comparable sign, and I'm usually someone who just doesn't necessarily check joint mobility as like my first go-to, right? It's just like not staple for me. I will say that for headaches, if they are symptomatic or asymptomatic, that is something that I usually will go to. Actually, I will usually check like their upper cervical mobility, some of their lower cervical mobility as well too. This is where I actually do the flexion rotation or the rotation with lateral flexion test to see like what exactly is going on. Is there a difference side to side? And sometimes when you just have a patient move and there may just not be enough force. So when you push on it, if that recreates some symptoms, if that recreates something that is relevant, I think that gives you plenty of information that you can continue to work off of as well. But the one thing I wanted to ask you, Mark, was when I started assessing people for repeated motions, or even for like just seeing how they're going to respond mechanically, I started sustaining people a little bit more when it comes to maintaining retraction or maintaining extension or rotation, and seeing how their symptoms change with that. And it's something that I've noticed is if they are asymptomatic and they're having some sort of deficit in that area, if they're lacking rotation or something, and I have them stay in that position, their headache usually comes on pretty quickly. So I don't know if that's something that you've noticed or played around with, but it's something that I started doing not too long ago.
Yeah, I've certainly played around with it. Now, it's interesting because at least the headache patients I've seen, they typically aren't the ones where, it's like, oh, every time I do this, I have a headache, right? It doesn't really, it's just not the presentation. Usually it's like, I go through my workday and I'm sitting, and then it starts around noon, and then it lasts for this amount of hours, right? They can't get rid of it, something like that. It's not typically like an acute onset headache and it lasts for 2 minutes, right? Where like sometimes in our radiculopathies, we can see where, I get this arm pain and it shoots down, but then I get up and move around, it goes away, right? Something like that. That's not usually what we see with the headache. So when you talked about it can, in our mechanical exam, sometimes it's hard to produce a symptom. So you really want the people to come in when they have headaches. And like you said, like maybe it's like you talked about sustain to bring it on. Sustain can be the answer as well. But then, like I was saying, at least subjectively, what I noticed is that, and I think you would agree with this, the presentation usually isn't something where it's like, acute onset headache. I turn my head to the right once and then I feel the headache. It's usually something that it just kind of builds over time and then levels out, right? So sometimes sustain can be the answer. And then something, like you said, sometimes you can bring it on with a sustain, which at least in my interpretation matches what I'm hearing subjectively for that when I am treating people who have headaches. I don't know if there's anything like, any data or like, direct link between that. Just anecdotally, I guess something I've noticed.
Yeah, I think it's just one of those things where I have started to pick up because I'm able to create a comparable sign then. And then also I'm just kind of leaning into the deficits that I'm seeing, right? It's just like, okay, there is a discrepancy side to side. What happens if I push you in the side that you're restricted on? Does it change your symptoms? And that honestly could be the answer or the treatment for you. I can't say that for sure, depending on the patient. Everyone responds a little bit differently, but at least it gives you something, an indicator to work with. Because when you just don't have anything to go off of, when their symptoms are kind of like up in the air, you don't know when they come on, they can't bring them on consistently and stuff like that, it makes your job so much harder, because then you are essentially just relying on your patient to be an accurate historian and data collector for you.
Yeah, you just don't have objective data to work with, right?
Yeah, for the most part. And this is where like recreating that is going to be helpful for a lot of clinicians.
So, I mean, I just want to emphasize this point a little bit more. Like having someone come in when they have the headache symptoms it's crucial to the assessment of this population. I mean, you have someone come in without a headache, their objective exam is just like completely different than if they come in with symptoms. I mean, the degree of movement loss, the symptomatic response, like I said, it's different than our radiculopathy type presentations where, maybe you add a tiny bit too much force, a little bit too many reps, and they start to peripheralize. Headaches sometimes, like when they're good, they're good. And then when they're there, they're not good, right? So having them come in while they have symptoms is crucial to establishing a pattern and continue with the correct management.
Yeah, the one thing that I'll say is I'm pretty sure you'd agree with this. When it comes to radic, when you're doing your repeated motions testing, short, you can make really rapid changes and completely centralize and abolish their symptoms, right? That I think that that's pretty common knowledge at this point, or at least common enough because we've discussed it ad nauseum.
Yeah.
The other way that that can flip is that instead of it rapidly centralizing and abolishing, it rapidly peripheralizes. Things just take a turn for the worse, and it's like, I can't bring them back. I pushed them too far, and now we got to give it a couple of days to chill before we can do anything else. That can definitely happen for Radic. I don't usually see that for headaches. It's like, maybe if we can get it to go away, we can get it to go away fast. Awesome. I do see that. But if we bring it on, it's usually still pretty gradual. It isn't something where it's like, I have them continue to do it and they're like, oh man, it's like terrible. I can't deal with this anymore. Yeah, that is usually not the presentation that I see. Do you notice the same thing, or what do you typically see for when you're provoking symptoms for them?
Yeah, I mean, sometimes they're just hard to turn on. I mean, I've definitely had it where the person has left the clinic and their headache's been worse, but luckily I haven't had it where
it's been like, is the question.
Like, listen, I don't ask a 0 to 10 scale, but let's say they were 0 and they left at a 3, and
okay.
They're not like lit up and like can't drive home type thing, right? It's just kind of, hey, my head's bothering me now, and it wasn't when I came in. And yeah, it's a little bit of an awkward conversation, but it usually works out. But yeah, usually they're not, it's not like you're really throwing them into a full-blown migraine just by having them move. Like I said, usually it's just like a gradual onset type thing.
Yeah, because like Radic, I've seen some people go from like 1 to 2 straight up to like an 8 or a 10. And you're just not, not bringing them back. But for headaches, that's just typically not something that I see too often.
Thankfully, yeah. All right, so we talked about objective. We talked about what we look at mechanically, movement laws. You talked about like a manual assessment for the spine. What does treatment look like? What's your go-to? Anything else you throw in there? Or we can take this step by step. What's your go-to? It's probably my go-to as well.
Brother, I was gonna say, you already know
when I get
answer to this, man. So just like anything spine related, my go-to is always MDT as a first line of defense. It is just so good at being able to effectively and efficiently screen upper and lower cervical spine. Right? Super, super helpful. Very, very repeatable as well, too. And this way, patients know what you're doing if you're explaining it to them. It just makes the treatment so much easier for them to understand and grasp, and for them to understand their role as well, too, as someone who is going to collect that data, report back to you, and tell you what their findings are. I think that that is just so, so helpful and important. But I know Mark's excited about this. So, Mark, what are some of the, let's start off with like some of the, I guess, basic MDT movements that you typically will see, that you'll typically do. And then after that, we'll follow up with like some of the more like nuanced or niche
for sure.
different treatments that you may do.
So, with our MDT approach, we're always starting sagittal, right? So just like radiculopathy is typically the most common movement that's going to provide, that most people are going to respond positively to, is a retraction progression. Now, the one caveat to this is that when radiculopathies, we talked about restoring lower cervical extension and quote unquote closing the joints. For headaches, we're looking at almost, you can call it like opening, gapping upper cervical. So we're focusing on upper cervical flexion, where if we go through a retraction progression and we're not getting the response we're looking for, or they're hitting a yellow light, we can add upper cervical flexion to retraction by having the person put their hands behind the top of their head and then adding flexion after the retraction. Then we can look at pure flexion, and then we can start to look at lateral components, right? We can add rotation. Rotation is going to be coming from those upper cervical joints. We can play with the combinations of retraction and rotation. We can, if we really want to get crazy, we can look at flexion and then rotating. So it's really interesting how you talk about the flexion rotation test in terms of looking at the upper cervical joint mobility. From the MDT approach, we can use it as a treatment. Hey, you're not moving as well there. Why don't you just bring your chin to your chest and then turn towards that side and keep doing it? See what happens. Do you get any symptomatic response? Does your movement get better? And then after that, you can basically just play around with whatever you want. But typically, if you've gotten that far in this kind of progression and you've added overpressure, you've sustained things like that, you're going to get some kind of symptomatic response. At least in my experience, I find like a good chunk of these people respond just to retraction-based movement. Sometimes, overpressure, sustained, maybe rotation. But if you're starting with this, I feel like you'll get most of the way with retraction. So that's the typical progression there. Except the only thing that's different is, and when we're looking at the arrangements, we really don't need to think about this, but we're looking to target upper cervical flexion through the means of retraction.
Yeah, and I definitely agree with that. For the most part, what I'm seeing is people are going to respond, just like Mark said, to the retraction progression, right? Like you want to make sure you're getting all the way through that you are exhausting that before you move on. The second thing that I'm noticing that people will usually respond with, if they are not doing super well with the retraction progression, is going to retraction extension. I find that usually helps people out. That's my next go-to if the retraction progression doesn't seem to be doing the job and closing everything out. The third thing that I usually will go to is a sustained hold of retraction or the flexion with retraction. So it's essentially like doing a suboccipital stretch for people who are listening. You're essentially just doing capital flexion, touching your chin to your chest, and then you're retracting from there and seeing how that affects their symptoms. I've seen a lot of times for patients who do have headaches that are a little bit more finicky, they just need a little bit more time. Maybe it's the amount of time that they're spending in one static posture that's kind of bothering them. And so they just need to spend a little bit more time at the opposite end range. I find that they usually will respond pretty well to that. I know like one of my colleagues does the prone on elbows, and she places her hands like on her chin, almost like she's praying, and that just gets you into that extension moment, and you can sustain that, so you gotta play around with some of the forces that you're able to do so to progress these exercises. That's the big thing, is like for MDT, it's not like anything that's like crazy. You have a finite list of these movements, and then you also have a finite list of variables that you control for your forces. You're just playing around with those and seeing what best works for your patient. And I do think that the rotational aspect can play a role, but it's not something that I see terribly often. So if you're new, I wouldn't even worry about the rotational aspect. Stick with those things. You're going to get the most bang for your buck with them. And that's going to make it so much easier. Once you've finally gotten a grasp on that, sure, then you can make it a little bit tougher. That's when you can start to add in more of the sustained forces, and then maybe adding in that flexion. Then lastly, adding in the potential lateral component to see if that makes a difference for your patients, right?
Yeah, like Kane said, like this isn't, just because it's a headache presentation doesn't change anything with how you're assessing the person. So you're using a movement. If you want to use the McKenzie MDT progression, I would certainly encourage you to do so. But you can take other kind of movements that are restricted or other kind of interventions that you like and just apply these kind of, test, retest, symptomatic response principles. But it really shouldn't change your assessment too much. I mean, like we keep saying, you're implementing an intervention, you're looking at the symptomatic response, and then that will dictate the management of your presentation going forward. So again, like if you're going to use this MDT type response, you're still the other aspects. If it ends up being a derangement, you're still treating like a derangement. You're giving postural type advice. You're talking education them on centralization of the headache. You're educating them on the self-management and symptom monitoring so they can manage this on their own. But yeah, so just because go ahead.
When it comes to MDT and headaches, do you typically mob people? Are you doing that often?
But I'll do the retraction mobilization, sure. And there's a upper cervical flexion cervical flexion mobilization supine as well, which is basically the flexion rotation test with overpressure without rotation, right? I can't say I've had to do that, but yeah, man, I'll mow people. What? They're an issue? Nah, it's just like this. I follow the force progression, right? So retraction, patient overpressure. We go to clinician generated forces, which would be our retraction with clinician overpressure, and then we have retraction mobilization. Sure, the last headache responder I had, well, not the last one, maybe a couple ago, they ended up we started with patient-generated forces. Each time they came back, they were a little bit better, but they were yellow. And we got the thing that did it was a retraction mob. That's what ended up they needed to get to abolish. So, yeah, if they need more force, then I'm going to give it to them.
So I think it's fine that regardless of how complex MDT gets, Mark always follows the force progression. He just knows
I'm a good boy.
He just knows where to go and what the symptoms are telling him, and then being able to interpret that. I think that if people could take away anything about following MDT as a framework, that is probably the number one recommendation that I would have, is to follow your force progression and understand the symptom response that you're getting, being better at interpreting that.
Yeah. And just because it's just because someone comes in and they may have weird symptoms and it's headache, behind the eyes, stuff like that, doesn't mean we have to count them out when they still are owed a mechanical assessment as long as they're safe to be in PT. So
it doesn't mean that anything has to change, right?
Yeah, exactly. So why don't you tell me, you talked about upper cervical testing, and in terms of segmental mobility, joint mobility, stuff like that, if you find that they're limited, what kind of interventions do you apply?
Yeah, so this is usually my second line of defense. And just as we talked about mobbing for MDT, you can absolutely still do your traditional manuals when it comes to upper cervical. So if I am doing a flexion rotation test, or if I am able to reproduce their symptoms when it comes to the rotation lateral flexion test, right? That is usually a pretty good indicator for cervicogenic headaches. So if they are not responding particularly well to repeated movements, that's when I'm much more likely to just start mobbing them, depending on where their deficits are. So for upper cervical, this is one where I find a couple of, interventions to be very, very effective. The first one is, I'll start off with the most conservative and then the most aggressive. So the first one I would say is doing your muscle energy techniques. So doing contract, relax, I think is really, really helpful. That way you're able to help them get further and further into their restriction and improving on that deficit. If someone's really lit up, honestly, you can have them turn, but that may be too much, turning their head into your hand as an isometric contraction. That may still be too much. For some patients, I've had to tell them, just look with your eyes. And that is enough to get muscular activation for them to get that input and start to calm things down a little bit more. The second thing that I'll typically do is I will mob the crap out of C2. This is one of the techniques that I learned from one of my mentors, and it is where they lay prone, head is just off axis to the side. And then from there, you are pressing directly on the articular pillar of C2. I think it is fantastic. I absolutely love this MOB. Patients do not like this MOB. It is very, very uncomfortable. It reproduces their headache almost instantly. It is intense. Grade your pressure and grade it well, because your patient may jump off the table and they may not like you if you don't give them
use
a
restraints.
Yes,
so you're applying these
is.
interventions, and you're still. So talk to us about how you are gauging a symptomatic response. Is it similar to their MDT type approach, or are you expecting symptoms when you're moving, or what's that look like?
Yes. Yeah. So I think I still apply the same kind of rationale that I do for MDT. If I provoke their symptoms, I'm going to push on it. I'm going to see, hey, does it change? Right. It's the same thing when you do soft tissue. They're going to hate it while you do it, but do they get a lasting effect afterwards? Are they able to move better? Is their pain better? Period. Right. So same thing goes for here. If I push on it, does it recreate your headache? Okay. Now, if I continue to push on it, does it change? And then you can test and retest, right? Maybe they had limitations in flexion rotation. Maybe they could reproduce their headache with a rotation lateral flexion test. Now, what's going on? Is that still as positive? Is it better than it was before? These are all the things that I'm continuing to constantly reassess. I treat it the same way as I would for MDT, even though it's a different tool that I'm using, right? So I think that just kind of goes to show you, like, when I say that I use different tools, but I still utilize the same framework, this is how it kind of matches. So I'm still reassessing every single time after I've applied an intervention just to see, are things getting better? Maybe they just need some time to get things moving a little bit better, and then they can respond to repeated motions again, and they can be reclassified. But that MOB, the C2 MOB, I think is absolutely fantastic. And then lastly, I'm not a huge fan of cervical manips unless like someone desperately needs it, like they're just like locked up and they're like, oh, I feel like it just needs to crack and it just won't go. But for upper cervical, I think it is fantastic. It is such an impactful way of addressing hypomobility here, right? And so usually for upper cervical manips, I'm definitely considering like C0, C1, C1, and 2 for sure. These two are like huge culprits where if you don't get them moving well, their headache is usually still going to persist, which is why Mark and I even talked about upper cervical repeated motions, just getting things to move better. But for this technique, I learned the distraction technique for both of those segments, and I think that they're significantly easier compared to any other cervical manip technique. It's just very quick. It's pretty comfortable for the patient, and they're usually just like, they're not really hesitant about it. So it just doesn't feel quite as risky compared to when you're adding in that
for the patient
component.
field. Those distraction based ones, they don't like and they're not like, it's not, their head's not doing much, right? I mean, you're taking up slack. This is like cup around the chin type thing, and then come up.
You're literally
right.
doing the football cradle.
Yes, exactly.
hold.
Yeah, I was just saying football hold. Yeah, so it's like, it's not like anything where you're like, the joints aren't per se getting. I was going to say get the end range, but you're not like cranking on their head or moving a lot. You're getting in there, and the distraction based ones, they're really not like invasive to the patient. I don't feel like you get a lot of guarding with them. You know what I mean? You can kind of get in there and do what you need to do, and then you're good.
Yeah, and the other thing that I'll say is when you're setting up your patients for these manips is they don't have to be manips. You can just distract them. You can sustain it. Yeah. You can oscillate. You can take your time, make sure that they're comfortable with it first, and that could be the treatment. Maybe you don't have to jump right away to a grade 5, and that's totally fine. Sometimes you don't need to drop a sledgehammer for something that could just need like a chisel. right? And
nice.
I think that is
okay. All right, I like that. I'm stealing that, man. So,
so
like,
that
will you get into that distraction type position, get into that pre-manipulative hold, if you will, and then you're asked how you feel here, and then you back off, and then if they, like, let's say you get into that hold, and you're like, actually, I feel 80% better. You can do like a sustained set, you can do some oscillations, you can mobilize there, versus will you, if they get that, a good symptomatic response just in that position, are you still likely to manip, or are you like, this is good enough?
nah.
Yeah.
Nah,
okay.
no shot. No shot. Cool. If I'm getting like a symptomatic response, why would I do something that would incur more risk
To look cool.
that can absolutely flare them up or God forbid something else happens, but I want to make sure that I use my tools as judiciously as I can. And this is where it's like, if I get a good symptom response, I'm not going to change anything. That's fantastic. We're already making really good progress here. All right. So we talked about MDT. We talked about upper cervical MOBs. Now here we're going to discuss a little bit more of, I guess I would consider them more like fringe or just like more niche interventions that we would do, especially if I'm just like, I'm not seeing a good response to any of the previous treatments.
It's interesting the way you describe it, because I would consider this more general.
What do you mean? The two that we mentioned?
Oh, no. The next couple.
Oh, yeah. Yes. They're more general they're more widespread across how people practice.
I think they're a smaller percentage of the headache population, but to me it's more of a general approach. But
yeah, I would definitely agree that more people tend to utilize these types of interventions, right?
Yeah. So,
and the ones that we're going to go to, or we've talked about this on the previous episode, but it's like periscapular strengthening, like improving posture, and then after that, working on deep neck flexors or like cervical motor control and stuff like that,
which I think at this point, at least from what I've seen, seems to be the approach that most PTs utilize, which I think is fine. It seems from a data perspective that it can be effective, right? I mean, like we talked about headache, typically responding to retraction. Well, if we look at this, the scapular strengthening and some postural type stuff, like usually people are encouraging upright posture and like pull your head back a little bit and, scapular retraction. You're kind of getting into that relative cervical retraction position. So it's kind of getting there. And I said, I don't see an issue with it.
Not quite. Not all the way.
Probably need a little bit more. But
still doing the chin tucks.
Yeah, you're almost there, right? But I guess my main thing is that people implement these interventions without going through a thorough mechanical assessment, and I think maybe the people who do respond to this more general approach could have gotten better faster. But let's say you've gone through your full mechanical exam. They're throwing you with a bunch of yellows. It's not, or maybe it's just not responsive at all. I think there is data to suggest that just the general shoulder, scapular type exercise can be beneficial in this population. I think in addition to just general aerobic exercise, I think all of that combined can be beneficial. And I think some of the studies that you look at, they kind of use this approach where it's just like, okay, you just do everything. And it's basically just exercise at that point, which is targeting the quote unquote problematic area, and they just track the outcomes over time. It's not necessarily like a derangement type thing where you're getting a quick, noticeable, lasting improvement in symptoms. It's kind of just like, all right, you're going to do this program for 8 weeks, and then we're going to see, rate your pain afterwards type thing. So I think I utilize that approach in patients who don't seem to be mechanically responsive, right? We can't figure out what makes it tick. If they have symptoms, it doesn't, maybe it gets a little bit better, but it doesn't stay better. It doesn't really get worse. It's just kind of there, right? And this approach, even though it may take some more time, it seems to be beneficial. So the thing I just typically don't do are the deep neck flexor type things. Kane, I think we're on the same boat here. Like listen, I don't know, man. I'm not getting the blood pressure cuff out. I'm not putting it there. I'm not going to be nitpicky about how someone's not utilizing their one muscle, and like this muscle needs to turn off and you can only lift your head up like this to do this exercise. That just sounds like a complete waste of time to me. When I see people do it, it seems almost laughable. I don't see how we're supposed to encourage movement as PTs when we're telling people that they're not allowed to pick their head off the table without, some certain little muscle that basically does nothing. That one's not allowed to kick in. I don't know, man. I don't do that. But the other general neck strengthening, scapular strengthening, yeah, I'll do it in patients who don't seem to be mechanically responsive. All right, I'm done. I'm not talking about the neck flexors anymore. You're up, Kane.
I will say, I think that the big thing is when you're doing those deep neck flexor exercises, right? Like, it just seems to me like we're over coaching, over cueing. It's the same thing where, like, when someone squats and you're like, no, you got to fix that. It didn't look the way that it should look. Like, it's not textbook. We can't do that. Right. It's some of these things people just need to move, and that's totally fine. Right. So that's one of the things that I've pretty much just moved away from. I just never really saw it as influential in my practice. So
Agreed.
I think the big thing that I actually wanted to touch on is something else that I typically do when I am having a troublesome case. If something just isn't working out for me, MDT isn't working out, it's not giving me the results that I want. Doing upper cervical mobs or manips just isn't it either. So there are a couple of other things that I usually will look for. And I definitely do soft tissue in other areas, but for the neck, I don't typically do it on. But this is one of those times where I've tried a whole lot of other things, and this is one of the things that I got to test out, right? I had a patient who I was like, there's no way that they're going to respond to suboccipital release. No chance. Like, I've tried it before. I've seen people do it for decades, and I'm just like, yeah, this is just fake. But lo and behold, this lady comes in and she's like, headache's still the same, not changing anything. It's still right there, points right to her suboccipitals. And I was like, you know what? Whatever. I'm going to do it. And we're going to see how it goes. It went away, completely went away. And I was like, I can't believe that that's it. Like, that was the key. So for some people, they may just have a very stiff and sensitive neck. Sometimes you just got to do some soft tissue work to get things to calm down, and maybe then they'll be more responsive. Right. So for stuff like this, a couple of areas that I'm looking for may be like their suboccipitals, like I said, and then usually the scalenes. But this isn't something that I jump to right away. They're just options that you have in case that the other two methods that Mark and I mentioned just aren't cutting it for you. And then the other thing that I have seen be relatively effective, depending on what's going on, once again, if it is a soft tissue thing or if it's like a hypertonicity issue, dry needling can definitely be effective, right? Like, I don't know about you, Mark, but I'm probably not going to do soft tissue on someone's temporalis for like an extensive period of time.
What about the frontalis, man? I think it's tight.
God.
It gets locked up, man. You gotta get
up in there, man.
yeah.
But what I will say is, for when you dry needle that, like, you just stick them real quick. It is virtually painless for a lot of these patients. And if it is a true soft tissue issue that is causing their headache, that's going to go away real quick. And if it's like a hypertonicity thing due to a ramped up nervous system, once again, that can definitely help. I know that for radic, dry needling is not the best intervention, but this is specific to if it is soft tissue or if it is like a ramped up nervous system. This can help to calm things down more to make their symptoms more responsive following. So these are kind of all the little tidbits that Mark and I would use to help treat majority of our caseload, as well as the ones that are more problematic. Mm-hmm. All right. So Mark, is there anything else that you want to toss in here for our headache episode?
No, I'm good. I think I'll just wrap it up. I mean, the main point that we want to get across is that when you're assessing headaches, like it can be treated the same as any kind of mechanical issue. I mean, it seems to be some overlap with cervical radiculopathy. So the same way Kane said in the beginning, if you can treat radiculopathy, you can treat most headache presentations, right? Determining if it's mechanical is your first step. Asking your red flag questions, making sure they're safe to be at PT, and then you're just going through the same standardized assessment that you would use for anyone else that has pain, right? We talked about different kind of treatments. I mean, we default to MDT, upper cervical mobilizations when indicated. I think that covers like really a gigantic chunk of these presentations. And then I said there's more of a general approach, right? There's kind of unresponsive type presentations where you're looking at more of so I think aerobic exercise is great for this population, in addition to some targeted type exercise for scapular, posture muscles, just some general shoulder strengthening, mobility. Yeah, just because it's there, deep neck flexor, sure, you can do that stuff. It's probably fine there. And then Kane mentioned at the end, like, listen, man, I won't speak any more about it. But hey, modalities can have their place too. But I like how Kane talked at the end. Like, I don't. The state that I practice in doesn't have dry needling, so I don't do it. But like Kane talked about dry needling, and he's using, if he utilizes it, it's test retest. Hey, we've tried all these other things that usually work. They haven't, but here's another option we can try. Poke. How do you feel? Better. Unpoke. It's still better. Okay, great, right? So it's something you can utilize, and then you can incorporate it into your treatment plan. All right. Well, that concludes today's episode of the PT Good Podcast. Remember to leave us a like, subscribe to whatever platform you listen to us on. Follow us on Twitter at PT Good Podcast. We thank you for listening. Hope you enjoyed, and we'll see you on the next episode.
I still love you. Bye.